In the emergency room, stories like this never begin with a confession. No one walks in and says, "I swallowed nails, keys, objects that were never meant to be inside a human body." They begin later than that, when pain has already replaced explanation, and when the stomach stops being a silent organ and starts demanding attention. Medically, this condition has a clear name, even if it sounds unreal. It is called Pica Disorder, a compulsive eating disorder that has nothing to do with hunger, taste, or nutrition. It is defined by the repeated consumption of non-food items, objects with no biological purpose, and often with serious physical risk. But the disorder rarely acts alone. In many documented cases, it is accompanied by what physicians call a bezoar, a dense, hardened mass of material the digestive system cannot break down or pass. When those materials are foreign objects, metal, tools, sharp fragments, the condition becomes a foreign body bezoar. This is the moment the stomach changes roles. Instead of functioning as a temporary passage, it becomes a sealed container. Objects do not dissolve, they do not exit, they accumulate. Metal presses against metal, edges grind against tissue. The stomach wall stretches, adapts, and endures forces it was never designed to tolerate. Pica is not a single incident or a moment of curiosity. It is a repeated behavior, sometimes continuing for years. A patient may swallow the same type of object again and again, or move from one item to another without fully recognizing the danger. By the time a bezoar forms, the problem is no longer only psychological, it is structural. When compulsive ingestion meets the body's inability to remove what has entered, the stomach becomes a trap, a quiet one. It works slowly, holding more than it should, until discomfort turns into damage, and damage turns into emergency. And that is when the question begins to form, often too late to ignore. If the human mind can push the body to consume what cannot be digested, how far can that process really go? Once that question is asked, the answers become unsettling very quickly. Because patients with pica do not stop at what seems plausible. They do not choose objects that are soft, small, or harmless. Medical records show a pattern that is difficult to accept at first, even for experienced clinicians. Nails appear again and again, long, rigid, rusted pieces of metal swallowed whole. Keys follow, house keys, locker keys, sometimes entire keychains. Coins stack on top of each other inside the stomach, forming dense metallic layers that refuse to move. Lighters, still intact, razor blades, broken glass, batteries, wires, fragments of tools that belong in workshops, not inside a human body. These are not isolated incidents or one-time accidents. In many cases, ingestion happens repeatedly, over months or years. Objects are swallowed one after another, sometimes deliberately, sometimes impulsively, sometimes without a clear explanation, even from the patient themselves. What makes this especially dangerous is scale. A single object might pass unnoticed, but repetition changes everything. The stomach becomes a collection point. Items settle into place, overlap, press together. Sharp edges do not disappear, they wait. Some patients return to hospitals multiple times with the same pattern. Others avoid care entirely until symptoms become impossible to ignore. By then, the volume of foreign material can be staggering. Dozens of objects, sometimes more, occupying space meant only for digestion. This is the moment where the condition reveals its true nature. Pica is not curiosity. It is not shock behavior. It is a sustained cycle, one that turns the digestive system into storage for things the body cannot forgive. And once the stomach has been forced into that role for long enough, it stops being a question of what was swallowed and becomes a question of when the damage will finally surface. By the time these patients arrive at the hospital, the act itself is rarely mentioned. They do not come in saying they swallowed anything at all. What brings them through the doors is the collapse that follows. The pain is usually the first signal. Sharp, persistent abdominal pain that does not ease with time. It grows instead, spreading, tightening, turning movement into something unbearable. Soon after comes vomiting, again and again, until the body has nothing left to expel. In many cases, bowel movements stop entirely. Gas cannot pass. The abdomen swells hard and distended as pressure builds inside. Sometimes there is blood, in the vomit, in the stool. Not always enough to be obvious, but enough to suggest that something inside has torn, scraped, or begun to bleed. At this stage, the patient is no longer dealing with a disorder. They are dealing with an emergency. What complicates everything is silence. Many patients deny swallowing anything. Some insist it is impossible. Others genuinely do not understand the danger of what they have been doing. Pica does not always come with awareness. The behavior can feel normal, routine, even invisible to the person repeating it. Emergency physicians are trained to look for common causes first: appendiculitis, obstruction, infection. But the symptoms do not always fit cleanly. Pain is severe, yet the story is incomplete. Imaging is ordered not because of suspicion, but because nothing else explains the presentation. This is the moment just before the truth appears. The patient lies on the table, still denying, still confused, sometimes defensive. The medical team prepares for a diagnosis they have not yet imagined, and within minutes, a single image will turn an ordinary emergency visit into something far more disturbing. Because the stomach, once silent, is about to reveal everything it has been hiding. The moment the imaging appears on the screen, the room changes. What physicians expect to see is obstruction, gas buildup, maybe a shadow suggesting inflammation. What they actually see is something entirely different. Bright, unmistakable shapes fill the stomach, sharp outlines, dense clusters, metal reflecting light in ways no biological structure ever could. Dozens of foreign objects sit piled together inside the stomach. Nails layered over coins, keys resting against wires, batteries pressed into corners of tissue that was never meant to hold them. Sometimes the mass does not stop there. Individual pieces have slipped forward, extending into the intestines, creating a chain of damage beyond the stomach itself. There is usually a pause, not because the diagnosis is unclear, but because it is so unexpected. Even experienced doctors are momentarily silent when faced with it. The image does not look real at first glance. It resembles an industrial scrap heap more than a medical scan. This is the point where denial ends. The patient may still insist they never swallowed anything, but the evidence is no longer abstract. It is visible, measurable, undeniable. The stomach has become an inventory of objects the body cannot escape. These images are not rare anomalies. They are documented, archived, and published. Case reports in medical journals show X-rays and CT scans filled with metal, each one attached to a real patient, a real surgery, a real risk of death. What makes the shock deeper is precision. Every object is intact. Nothing has dissolved. Nothing has softened. The digestive system has done exactly what it was designed to do, except here that design has been exploited beyond its limits. The scan does not just reveal what is inside the body, it reveals how long the process has been happening. Objects do not collect like this overnight. This is accumulation, repetition, time. And once the image is seen, the question is no longer what is wrong. The question becomes how much damage has already been done and whether there is still time to stop it. Once the images are seen, the case stops being theoretical. It becomes a record, a sequence of events documented not for shock, but because it happened. One widely reported case involved a man who arrived at the hospital with severe abdominal pain and vomiting. The scan revealed the cause. Inside his stomach were more than 30 nails mixed with keys, coins, and lighters. The objects were stacked together, some already pressing dangerously against the stomach wall. Emergency surgery was the only option. Surgeons opened the abdomen and removed the contents piece by piece, laying them out one by one. Against expectation, the patient survived. The case was later published in emergency surgery journals, not as a curiosity, but as a warning. Another case pushed the limits even further. A psychiatric patient was found to have swallowed more than 100 metallic objects. The accumulation was so extensive that some pieces had already pierced the stomach lining. Internal bleeding had begun. Infection was imminent. One operation was not enough. Surgeons had to intervene twice to control the damage, repair the tissue, and remove what could be reached. Even then, survival was uncertain. This was not a stable condition. It was a narrow escape. Then there are cases that follow a different pattern altogether. In prisons, deliberate ingestion of metal objects appears with disturbing frequency. Inmates swallow screws, wires, fragments of tools. Sometimes the motive is to be transferred to a hospital. Sometimes it is an attempt to escape confinement. Often it is tied to untreated psychiatric illness. The behavior is calculated, but the consequences are not. Many of these patients return repeatedly, each time with new objects inside them, each time closer to irreversible injury. These cases are not isolated. They appear again and again in emergency departments, psychiatric facilities, and correctional institutions. Different backgrounds, different motives, the same outcome. A stomach filled with objects it cannot process, and a body pushed into crisis. What makes these reports especially disturbing is their consistency. The pattern repeats across countries, hospitals, and years. The details change, but the mechanism does not. Compulsive ingestion leads to accumulation. Accumulation leads to injury. Injury leads to surgery, or worse. By the time these cases reach publication, they are no longer stories about unusual behavior. They are evidence of how far the body can be forced to endure what the mind has already lost control over. What often surprises doctors, and alarms them just as much, is that the stomach does not fail immediately. From the outside, it seems impossible. Sharp metal, rigid edges, foreign weight. And yet, in many cases, the stomach holds. Not because it is invincible, but because it is built to endure more than we realize. The stomach wall is thick, layered, and muscular. It is designed to churn, compress, and resist constant mechanical stress. For a time, it can absorb impact without tearing. Some objects settle into positions where they do not pierce right away. Others become coated in mucus, the body's own protective barrier, which temporarily reduces friction and irritation. The stomach adapts, reshaping itself around what should never be there. This creates a dangerous illusion of stability. Pain may come and go, symptoms may remain mild, the patient may believe nothing serious is happening. Inside, however, pressure is slowly increasing. Edges rub against tissue with every movement. Blood flow is compromised in small areas. Micro-injuries form where the wall is weakest. The stomach is not healing, it is tolerating, and tolerance has a limit. The same strength that delays catastrophe also masks it. Damage does not announce itself when it begins. It accumulates quietly until one movement, one shift, one additional object turns endurance into rupture. That is why this condition is so deceptive. Survival in the early stages is not safety, it is a countdown. Because the stomach is not meant to be a container, and once its defenses fail, they fail all at once. The real danger does not arrive loudly. It waits. For days, weeks, sometimes years, the body holds together under strain. And then, without warning, the balance breaks. A sharp edge shifts. A weakened section of tissue finally gives way. What was contained becomes a catastrophe. A perforation is often the first collapse. The stomach or intestine tears open, allowing bacteria, acid, and partially digested material to spill into the abdominal cavity. Pain escalates instantly, but by then the damage is already spreading. Bleeding may begin internally, unseen, draining the body faster than it can compensate. If infection takes hold, the situation becomes far more dangerous. Sepsis does not stay localized. It moves through the bloodstream, overwhelming organs that had nothing to do with the original injury. Blood pressure drops, consciousness fades, time becomes the enemy. In other cases, the outcome is mechanical rather than infectious. A complete bowel obstruction forms when objects block passage entirely. Nothing moves forward. The intestines swell, blood supply is cut off, and tissue begins to die. Without rapid intervention, this alone can be fatal. What makes these outcomes especially cruel is timing. Many patients arrive too late. They come only after pain becomes unbearable, after vomiting turns relentless, after collapse is unavoidable. By the time imaging confirms the cause, perforation or infection has already begun. At that point, treatment is no longer about prevention, it is about damage control, emergency surgery, intensive care, a fight to stabilize a body that has been under silent attack for far too long. This is why the condition is so dangerous, not because the body fails quickly, but because it fails suddenly. The delay creates false reassurance until the moment when there is no margin left. What looked survivable becomes irreversible in hours, and what began as swallowed objects ends as a full-scale medical emergency that few see coming in time. By this point, the question can no longer be avoided. Why would a human being do this to themselves? There is no single answer, and that is what makes the condition so difficult to understand and so easy to misjudge. In many cases, pica appears alongside severe psychiatric illness, disorders that alter perception, impulse control, and judgment. Schizophrenia can blur the boundary between thought and action. Severe depression can hollow out the instinct for self-preservation. Bipolar disorder, especially during manic phases, can push behavior beyond risk into compulsion. Certain personality disorders turn pain into something that must be expressed physically when it cannot be spoken. In these states, swallowing foreign objects is not a choice in the usual sense. It is an action driven by forces the patient cannot easily name or resist. There is also a biological layer, though it explains far less than people often assume. In rare cases, deficiencies in minerals such as iron or zinc can trigger cravings for non-food substances, clay, ice, chalk. This is documented and real, but it does not explain nails. It does not explain razor blades, batteries, or shards of metal sharp enough to tear tissue. Biology alone cannot account for that level of harm, which leads to the most uncomfortable explanation. For some patients, the act is behavioral, a way to be seen when nothing else works, a way out of an unbearable environment, a method of converting invisible psychological pain into something concrete, measurable, and undeniable. In prisons and institutions, swallowing objects can become a language, a way to force transfer, attention, or temporary escape. In others, it functions as indirect self-harm, not a direct attempt to die, but a willingness to accept serious injury as a form of control. What connects all these reasons is not a desire for metal or glass or objects themselves. It is distress without a safe outlet, a mind under pressure, finding a path through the body. This is why treatment cannot stop at surgery. Removing the objects does not remove the drive. Closing the wound does not heal what caused it. Without addressing the psychological core, the cycle simply resets. The stomach empties, the pain fades, and sooner or later, the behavior returns. Because this condition is not about what is swallowed, it is about what the person is carrying long before anything reaches the stomach.
This is what makes the condition so resistant to resolution. From a surgical perspective, the problem seems clear. Remove the objects, repair the damage, stabilize the patient. But medically, that is only the surface. The deeper cause often remains untouched. Many patients repeat the behavior, not days later, but weeks or months after recovery. Some return to the same hospital with new foreign objects inside them, even after surviving a life-threatening operation. The relief that follows surgery is physical, not psychological. The impulse that drove the ingestion is still there. This is why surgery alone fails in the long term. It treats the consequence, not the source. Each operation carries its own risks, adhesions, infections, scarring, weakened tissue. The body becomes less resilient with every intervention. What was survivable once may not be survivable again. The danger compounds over time. Repeated surgeries increase the chance of catastrophic complications, a tear that cannot be repaired, an infection that spreads too fast, an obstruction in tissue already damaged beyond recovery. At some point, the margin for rescue disappears. For physicians, this creates a grim dilemma. They can save a patient today, knowing that the same behavior may bring them back tomorrow in worse condition. Without sustained psychiatric care, the cycle continues, and each return is more dangerous than the last. This is why treating pica with foreign body accumulation is never a single event. It is a long, fragile process that demands coordination between emergency medicine, surgery, psychiatry, and long-term supervision. Miss one element and the entire effort collapses. The hardest truth is that success cannot be measured by survival alone. Because in this condition, surviving the operation does not mean surviving the pattern.
Once the condition is recognized, treatment becomes a race against time. The first priority is always physical removal. If the objects are accessible and have not caused extensive damage, doctors may attempt endoscopic extraction. A flexible camera is guided into the stomach, and instruments are used to retrieve what can be reached. This approach is less invasive, but it only works when the accumulation is limited and complications have not yet begun. When bleeding, perforation, or complete obstruction is present, there is no alternative. Open surgery becomes unavoidable. The abdomen is opened, the stomach or intestines are exposed, and the foreign material is removed manually. Surgeons work carefully, knowing that every sharp edge has the potential to worsen the injury. The goal is not elegance, it is survival. But even when surgery is successful, everyone in the room understands something crucial. The operation has solved today's crisis, not tomorrow's risk. That is why psychiatric treatment is not optional, it is essential. The underlying disorder must be identified clearly. Medication may be required to stabilize mood, perception, or impulse control. Long-term behavioral therapy is often necessary to interrupt the compulsive cycle and replace it with safer coping mechanisms. Without this second phase, the outcome is predictable. The wounds heal, the patient is discharged, and sooner or later the behavior returns. Another ingestion, another emergency, another operation, each one more dangerous than the last. This is what makes treatment so difficult. Medicine can remove metal from the body. It cannot, on its own, remove the force that put it there. Only when surgical intervention and psychiatric care move together does the cycle have a chance of breaking. In this condition, saving a life is not a single act. It is a sustained effort to stop the same life from being placed in danger again.
Prevention is possible, but only when the risk is taken seriously before another emergency occurs. In controlled environments like prisons, prevention begins with restriction, continuous monitoring, limiting access to tools, metal objects, and anything that can be swallowed intentionally. Staff are trained to recognize patterns, repeated complaints, unexplained abdominal pain, sudden requests for hospital transfer. When these signs are ignored, the outcome is predictable. Another ingestion, another crisis. In psychiatric facilities, the approach must go further. Supervision alone is not enough. Patients at risk require structured, long-term treatment plans, regular psychiatric follow-up, medication adherence, behavioral therapy that addresses not just the action, but the reasons behind it. Progress is often slow, and relapses are common, but absence of structure almost guarantees repetition. What makes prevention difficult is that it demands consistency. Gaps in monitoring, missed appointments, relaxed supervision, these are the moments when the behavior returns. The disorder does not pause because conditions improve temporarily. It waits. This is why neglect is so dangerous. Not dramatic neglect, but quiet neglect. Assuming the problem has passed because the surgery was successful. Assuming insight will prevent recurrence. Assuming one intervention is enough. In this condition, it never is. Every swallowed object is part of a pattern, not an accident. Breaking that pattern requires vigilance long after the hospital discharge. Without it, the cycle resets, and the next emergency is often worse than the last. Prevention does not look heroic. It looks repetitive, controlled, and relentless. And without it, the catastrophe does not just repeat, it escalates.
What is often forgotten, quietly pushed aside beneath the scans, the surgeries, and the shock, is the human being at the center of all this. These patients are not curiosities, they are not spectacles, and they are not crazy in the shallow, dismissive sense the word is often used. They are people in pain, pain that did not start in the stomach and was never truly about the objects themselves. For many of them, the body becomes the only language left. When psychological suffering cannot be expressed, explained, or relieved, it finds another outlet. The stomach fills because the mind is overwhelmed. The injury becomes visible because the distress was invisible for too long. From the outside, the behavior looks irrational. From the inside, it often feels inevitable. A compulsion, a release, a momentary sense of control in lives shaped by chaos, confinement, illness, or neglect. The metal is not the point. The act is not the goal. It is a symptom of something far deeper. In hospitals, these patients are sometimes treated as problems to be managed rather than people to be understood. Repeated admissions, repeated surgeries, quiet frustration among staff, but behind every recurrence is a story that was never fully addressed. Their bodies carry the evidence of psychological wounds that never healed properly. Scars on the stomach mirror scars in the mind, And while surgery can remove what does not belong inside, it cannot erase the suffering that put it there. This is the part that rarely makes it into case reports or medical journals. The reminder that behind every shocking image is a person whose body became the last place their pain could go. And unless that pain is acknowledged, not just treated, the cycle continues, silently demanding attention in the only way it knows how.
In the end, the truth is simpler than the images that reveal it. The stomach was never designed to be a storage space, not a container, not a shield against metal, glass, or sharp edges. It is an organ built for digestion, not endurance against abuse. When it is forced into that role, it holds on only as long as it can, quietly, without warning. What fails first is not the body, but the mind. And when that collapse goes unnoticed or untreated, the body becomes the place where the cost is paid. Damage accumulates silently until pain arrives not as a symptom, but as a consequence. Pica disorder is not just an eating disorder. It is not about unusual cravings or strange behavior. It is a condition that turns psychological suffering into physical risk. A disorder that hides behind tolerance and delay, then reveals itself suddenly, often at the edge of survival. There is no dramatic countdown, no clear signal that death is approaching, only accumulation, pressure, and time. And that is what makes it so dangerous. Because when the mind breaks down, the body does not protest immediately. It absorbs the damage. It adapts. It waits until it can't.